Bismillahirrahmanirrahim. Salatu wassalamu ala Rasulillah. So, my talk it will be the optimizing the therapy for elderly AML patient in 2019, and it's a fact that the median age of AML patient usually is an elderly around 68, and most of them they have difficulty, or they will be faced on difficulty treating them because they have comorbidities plus the biology of the AML itself that it preclude to not to give the optimal treatment and the standard treatment. Even for those sick patients, they are fit, still the outcome is dismal comparing to the young generation. Now, in 2008, we should not speak about high dose therapy, as we have now a plethora of medication that has been targeted agent and combination that it shows some excellent response and excellent outcomes. It's clearly since the last, since 1970, there is no clear improvement of the survival of elderly AML. Still is being plateau, and we do not have really the good outcome with the standard therapy that they are receiving. Either they are receiving very intensive therapy that for those we consider that they are fit, or they are palliative treatment in the palliative treatment group with the use of blood transfusion, hydria, and low dose RC. They do worse because it's a multifactorial. It's related to the patient himself. They have comorbidities and their performance status is not that great. And this biology, we know those AML type, they are more accumulating cytogenetic abnormalities that it is resistant to chemotherapy, and also they have different mutations that it is prohibited the outcome or decreased the outcome. Having said that, since the last 5 years, there is significant improvement of the survival of AML patients because there is improvement of the supportive care, infection, blood transfusion, and now we are not talking about high-dose therapy. We're talking about tailoring the therapy to the AML patient based case by case, rather than just to give them all those patients, just give them standard treatment. And the last thing is the expansion of the role of allogeneic stem cell transplant. Yet we are, with the use of reduced toxicity, reduced intensity transplant, even hybrid transplant in those age group, improve survival. So that's one of the things that once you achieve CR, you have to consider this patient for transplant is not in the favor of the patient, rather than just to omit the transplant because of his age, about 60. This is a retrospective data looking to the two factors that affect the day 30 mortality, which is performance status and the age. So if you are looking to the performance status 0 to 1, the age has modest effect. It's not that significant impact. However, when the patient had performance status 2 to 3, the chance of this patient die from the intensive chemotherapy is 82%. So that's the message that clear for us that the performance status is the most important one. The standard that we give for therapy for those fit patients, that it's a minimal percentage of the patient will be fit for standard therapy. They, based on their age, those above age of 60, they do poor, irrespective of the leukemia type, because if you see the de novo AML in age less than 60, the 5-year survive around 40 to 50% at the plateau. However, in age more than 60, with the use of the same therapy, still the outcome dismal and less than 20% in the 5 years. The reason multiple reasons behind those patients 60, they are not doing well. First of all, the accumulation of unfavorable cytogenetic and the percentage, and also in the type. And the percentage, if you are looking the less than 55 years old, the unfavorable cytogenetic represents about 35%. However, more than age of 75, the percentage goes up to 51. And also for the good risk, if you are less than 55, you are having a chance of 17% they have good risk cytogenetic, and it dropped to less than 4% in those patients more than 75. And within this group, the 51, we find the complex cytogenetic, the more resistant cytogenetic, which is 5, 7, and name it, and complex cytogenetic. Not only cytogenetic, but also molecular. As you go with age, if you see chart bar, the accumulation of the multiple mutation, it will end up by resistant leukemia to the standard therapy. One of the important questions that everybody is facing if you have a patient that is elderly and he had an acute leukemia and you want to decide about further plan management. And most of the time, we are seeing a patient, if he's walking without support, if he didn't have diabetes or hypertension and other comorbidity, we may think about to go for standard treatment, standard therapy. However, this is not enough. There have been some assessment tool with the first use of the comorbidity index, and it shows if you have more than 2, the chance of the CR and the chance of relapse, the CR will be low, the relapse will be very high for those patients with the performance status more than 2. There are also some clinical calculators. You can use it on geriatric assessment tool, which is, it can help you in the assessment of the prediction of those patients if they receive chemotherapy, what the chance to be cured, what the chance of they are be having treatment-related mortality. So there are 2 things that you have to consider when treating elderly patient: the patient evaluation and disease evaluation. And this is very important. There is a study, it was a clear study that mentioned that you didn't need to rush and treat patient with an elderly patient. Just you have to take your time, check cytogenetic, check molecular, unless those patients, they are like having an acute emergency like hypostasis or DIC. But if you have an acute leukemia, most of the time you need to have time to think about it, to see your patient performance status, see cytogenetic and molecular study before deciding about the plan of management. The treatment options, the approved and non-approved, I'll discuss it here very quick, inshallah. The upfront, the high intensity 7+3 CBX trial, the low intensity regimen, which has been recently approved for those patients with AML, and also off-label therapy. 7+3, this has been standard for the last 30 years. And we play around 7+3 by different things, either increasing the dose of anthracycline or changing the type of the anthracycline. Plus, now we have the flavor to addition of targeted agent. As we mentioned, has been said this morning, discussed this morning, the nimotuzumab, mycin, and FLT3 inhibitors. So this table shows most of the trial that addressing the different type of 7+3 in the way of increasing the anthracycline dose, changing the anthracycline, and the conclusion, the 7+3 with the dose of either robicin 12 milligram, daunorubicin 60 milligram, or mitoxantrone 12 milligram will be the standard of care for favorable risk. However, you get benefit of increasing anthracycline dose for those patients that are intermediate risk, and also FLT3 inhibitors. The AML patient, above age of 60, they do poor with standard therapy. So their chance of complete remission is 45%. The early mortality more than 25%, and disease-free survival is less than 20%. And it is proportional for the age. This is one of the improvement in addition of 7+3 is the addition of the gemtuzumab oligomycin, and it's clearly from the study we can say that gemtuzumab oligomycin is beneficial in those good risk group and questionable and intermediate risk group. Ratified study, I didn't want to go more. It shows clearly overall survival with the use of midostaurin. CBIC study, this is, as been said this morning, is a sort of liposomal anthracycline and cytarabine, and it has been compared with 7+3, and I don't want to go to the schema of the trial. And this is patient category, and if you can see, sorry, the median age above age of 60, and the performance status is good performance status for if you want to give this patient CBX trial. And the cytogenetic has been variable from different type, from good cytogenetic to poor cytogenetic. The outcome, there is clearly improvement in all survival, CR, CRI, and also lesser toxicity of CBX comparing to 7+3. And it shows overall survival. And you can see that its plateau and the median survival has not been reached with the use of CBX study. So in conclusion of this trial, the CBX 351 is superior to 7+3 in overall survival, event-free survival, CR, and CRI. And the mortality is lower with the use of CBX. Safety profile is almost similar. And overall survival of transplantation improved with CBX versus in comparing to the 7+3. And investigator conclude that CBX 351 is appropriate first-line therapy for elderly patients with high-risk AML, and with the chance those patients they may go for transplant. This is all therapy that I think it's not anymore being used because we have a lot of different agents now coming. With the low-dose RSC, it has been compared to hydroxyurea, and there is chance to get 18% to good CR. However, this is not persistent, and most of 100% of those they relapse. One of the important studies that I think is coming, and it will be very changing the paradigm of the management of the AML, is the use of the venetoclax plus hypomethylating agent. It has been compared to decitabine and also azacitidine. So this is the schema of the trial, and this is the patient population, and the cytogenetic, they incorporate more, even poor cytogenetic, and also those patients with T53 mutations and the FLT3 mutation. So irrespective of the molecular data, irrespective of the cytogenetic, it's working. So you have around 70 to 75% CR and CRI in any type of acute leukemia. And the irrespective of the cytogenetic, irrespective of the molecular data that you have. So the conclusion from this trial that an elderly patient with unfit for the standard therapy, the way to go is the venetoclax plus hypomethylating agent. It gives you the 71 to 74% response and CR, CRI. And then you have to decide about either to take this patient for transplant or to go with the continuation of the therapy. For that reason, the FDA approved venetoclax in combination with either with low-dose RSC or the venetoclax with the hypomethylating agent in AML patients. One of the oral medication that is being recently approved in the last year is the Glasgib with low-dose RSC. It's an oral therapy. It has the rule in low stem cell. It has a role in low stem cell eradications. So its activity is not, comparing to the venetoclax, is not that impressive. But I feel it has a role for those that have persistent disease and they may have minimal residual disease. It shows clearly, comparison to low-dose RSC, it has improvement of the survival probability. For that reason, it has been approved in elderly patients with low-dose RSC in age of 75. So, if I want to conclude, if I want to have a patient that he is elderly and in front of me, and then decide about the management. So, as it said, take your time, do good assessment, ask the palliative care to see him, for pain control, for modification of his performance status. Look to the disease biology in the way of the cytogenetic molecular data, and then you have to decide either this patient is fit for intensive therapy or he is not the candidate for the 7+3, or we're talking about the CBEX trial. So if this patient is fit for intensive therapy, either to go for clinical trial, FLT3 TKI, or FLT3 ITD, 7+3 midostaurin, or if you have AML dysplasia, you go for a CBEX trial. If it is unfit, you go for clinical trial, or venetoclax plus hypomethylating agent or low-dose RSC, or use of Glasgib with low-dose cytarabine. Again, maybe if you using single agent, if you have mutations, maybe again it's IDH1 or IDH2, and single agent rituximab, oligomycin. And with this one, very important to incorporate the best supportive treatment. Having said that, you have to think about transplant at any time point of the therapy, because mostly those patients, they are coming with poor performance status because of the disease illness. Once they recover from their disease illness, maybe you consider for reduced intensity transplant, which is the ultimate goal of the reducing the overall survival. Thank you very much.
Any questions, please? We'll take questions before moving on to the next. I'll start with the question. Dr. Zayed, is tools like the geriatric assessment tools that we can use in clinic, or are you aware of any apps or anything that you can use to?
There is actually, that's a good thing you haven't. There is app using the geriatric assessment. You can use it and you can assess your patient, which performance status, they give you more accurate data. Or the medical calculators. There is another calculator that you can upload the profiles of the patient, and then it can give you a hint where is this patient fitting in the performance status, rather than just by looking to the patient.
Any more questions? One more question. If you had access to venetoclax easily, would you start all your elderly and fit patients on venetoclax plus azacitidine, or would you try the azacitidine and then keep the venetoclax for later?
Well, the result is very impressive. I mean, if you compare the azacitidine and AML, that is give you around the overall survival more than around 3.8 months. However, in comparing to the azacitidine plus venetoclax, it gives you at least CR and CRI around 70%. So I think this is the way to go. It's not without any complication, because still like you face with neutropenia and transfusion dependence, but I think now it's not anymore challenging because we have good supportive care to deliver to those patients so they can go through the therapy without that much complication.
If there are no more questions, I'll invite Dr. Zayed to chair the next CLL session.